Picture this. A 68-year-old man walks into your clinic, newly diagnosed metastatic prostate cancer, PSMA positive on his PET scan. You start him on androgen deprivation therapy plus an ARPI. That's standard. But what if you could add something that targets the cancer cells directly with radiation? Something that buys him more time before progression?
That's the promise of radioligand therapy. And this week, The Lancet published the PSMAddition trial, the largest trial ever of this approach in first-line metastatic prostate cancer. The FDA has already approved it based on these results.
Good morning. It's Tuesday, August 11. 4 stories today. PSMAddition for metastatic prostate cancer. An Australian trial on postpartum blood pressure after hypertensive pregnancy, Azithromycin versus roflumilast for COPD exacerbations, and a trial that asked whether catheter ablation prevents stroke recurrence in atrial fibrillation. Let's go.
Back to PSMAddition. 1,144 patients, 20 countries, 169 sites, all with newly diagnosed PSMA-positive metastatic hormone-sensitive prostate cancer, randomized 1:1.
One arm got the current standard, androgen deprivation therapy plus an androgen receptor pathway inhibitor, think abiraterone enzalutamide, apalutamide. The other arm got the same backbone plus intravenous Lu-177 PSMA-617 every 6 weeks for up to 6 cycles.
Explain the mechanism for listeners who aren't nuclear medicine specialists. What does this drug actually do?
Lu-177 PSMA-617 is a radioligand. It's a molecule that binds to prostate-specific membrane antigen, a protein that's heavily expressed on prostate cancer cells. Attached to it is a radioactive lutetium atom, so the drug homes in on prostate cancer cells throughout the body and delivers a localized dose of beta radiation. It's precision therapy. The radiation travels only a few millimeters, so it kills the target cell while sparing surrounding tissue.
And the primary endpoint was radiographic progression-free survival. What did they find?
A 28% reduction in the risk of radiographic progression or death. Hazard ratio 0.72, statistically significant with a p-value of 0.002. At the second interim analysis, 24% of the treatment arm had progressed or died compared to 30% in the control arm.
28% relative reduction, but the median progression-free survival wasn't reached in either arm, so we don't have an absolute number in months yet. That's a limitation. The follow-up was about 20 months median. We need mature data to know how many extra months this actually buys patients.
Fair. But the FDA didn't wait. They approved Lu-177 PSMA-617 for first-line use in late July, just days before this publication. So this is already available in the United States. In Australia, it's available through the Therapeutic Goods Administration for metastatic castration-resistant disease. But this first-line hormone-sensitive indication is new.
What about toxicity? Adding 6 cycles of systemic radiation can't be free.
It's not. Grade 3 or worse adverse events were 51% in the treatment arm versus 43% in the control arm. The signature side effect was dry mouth in 46% of patients. That's because the salivary glands express PSMA, also cytopenias and gastrointestinal disturbance, but serious adverse events were only modestly higher. 32% versus 29%.
Dry mouth in nearly half the patients. That sounds tolerable on paper, but xerostomia can be genuinely miserable. It affects taste, nutrition, dental health, and cytopenias matter when you're giving concurrent treatment. This is not a trivial addition.
And there's a subtlety worth mentioning. 68% of patients in this trial had high-volume disease. That's the group with the worst prognosis. We don't yet know whether the benefit extends equally to low-volume disease patients, who have a more indolent course and may not need aggressive upfront therapy. That subgroup analysis will matter. No. And the trial allowed crossover. Control arm patients who progressed could switch to Lu-177 PSMA-617. That's ethically right, but it muddies the overall survival analysis when it matures. If the control arm gets the drug eventually, the survival curves converge.
So the bottom line for a GP or rural clinician, if you're referring a patient with newly diagnosed metastatic prostate cancer, PSMA PET imaging is now critical. It's not just for staging, it determines whether they're eligible for radioligand therapy. Test PSMA status at diagnosis, and discuss this option with their urologist or oncologist.
Exactly. The PSMA PET has become a gateway test. Tell your patients about it. Now, story 2, something for your wife.
Your wife sees patients with hypertensive disorders of pregnancy, preeclampsia, gestational hypertension. We know these women have a 2 to 5-fold increased lifetime risk of cardiovascular disease. The question is what we should do about it after they deliver.
An Australian team from the George Institute, led by Professor Amanda Henry and Professor Mark Brown at St. George Hospital in Sydney, just published the largest trial ever on this. It's called Blood Pressure Postpartum. 525 women across 6 Sydney hospitals, all had hypertensive disorders of pregnancy.
3 arms. Standard care. A single specialized postpartum clinic visit with education and counseling at 6 months. Or that clinic visit plus a 6-month phone-based lifestyle coaching program. The question was whether structured lifestyle intervention could improve cardiovascular risk in that critical first year.
And the headline finding is humbling. Lifestyle interventions helped with weight and waist circumference. About half the intervention group saw positive improvements there, versus 38% in standard care. But blood pressure did not improve. It stayed essentially unchanged between 6 and 12 months postpartum.
Let me make sure I understand the magnitude. Around 60% of these women still had at least 2 cardiovascular risk factors at 1 year. Roughly 1 in 5 were on blood pressure medication at 6 months, and the 6-month phone coaching program offered no additional benefit over a single clinic visit.
That's right. The lifestyle program moved the needle on body composition, but not on the thing that matters most for long-term cardiovascular risk, blood pressure. And the authors were transparent about this. Professor Henry said the findings emphasize the need for earlier, more targeted interventions, including medication.
This challenges the default approach. We tell these women to eat well, exercise, lose weight. And that advice is not wrong, but this trial shows it's not enough. The structural cardiovascular changes from a hypertensive pregnancy, the endothelial dysfunction, the vascular remodeling, those don't reverse with a phone coaching program.
And there's a timing issue. The intervention started at 6 months postpartum, but the cardiovascular risk clock starts ticking much earlier. By 6 months, many women already have established hypertension, persistent endothelial dysfunction, and metabolic changes. Starting lifestyle intervention at 6 months may simply be too late. What should change in practice? First, earlier postpartum follow-up. Don't wait 6 months. Check blood pressure at 2 weeks, 6 weeks, 3 months. Second, consider antihypertensive treatment more aggressively. These are high-risk women. Third, recognize that 1 in 5 will still need medication at 6 months, and that's not a failure of lifestyle. It's the disease.
And tell your wife about this one. The next time she sees a woman at her 6-week postnatal check after preeclampsia, the conversation shouldn't just be about lifestyle. It should include blood pressure monitoring, medication review, and a plan for long-term cardiovascular surveillance. This is a window of opportunity that we're currently missing.
Story 3. Back to general practice. You have a COPD patient on triple therapy who keeps exacerbating. 2 or 3 times a year, each one chips away at their lung function. You're considering adding an oral preventer, azithromycin or roflumilast. Which do you choose?
It's a genuinely common dilemma. Both drugs reduce exacerbations in trials. Azithromycin is a macrolide antibiotic with anti-inflammatory effects. Roflumilast is a phosphodiesterase 4 inhibitor, but there's almost no head-to-head evidence. A large randomized trial called Alliance is ongoing, but results aren't expected until late this year or next.
Into that gap steps a new study from BMJ, an emulated target trial using insurance claims data from 93 million people. The researchers compared real-world outcomes in patients with COPD who started maintenance azithromycin versus roflumilast. Over 13,000 patients matched on more than 100 covariates.
Emulated target trial methodology. This is the state-of-the-art for comparative effectiveness research when a randomized trial doesn't exist yet. You use rigorous causal inference frameworks to make observational data behave like a randomized trial as closely as possible. It's not as good as an RCT, but it's the best available evidence right now.
The finding: azithromycin was associated with fewer COPD exacerbations requiring hospitalization and lower all-cause mortality compared to roflumilast. The effect was consistent across subgroups, including patients with and without asthma overlap, and across eosinophil strata.
Now caveats: this is observational data. Propensity matching can't control for unmeasured confounding. Clinicians may choose azithromycin for patients they perceive as less frail, or roflumilast for patients with specific phenotypes. The trial emulation tries to handle this, but residual bias is inevitable.
Also, the side effect profiles differ. Azithromycin carries risks of QT prolongation, hearing loss, and antimicrobial resistance with chronic use. Roflumilast causes nausea, diarrhea, and weight loss, which can be significant. The choice isn't just about efficacy, it's about which toxicity your patient can tolerate.
Practically, when the Alliance trial reads out, this may all change. For now, if you need to choose today, this real-world evidence tilts toward azithromycin as the first oral add-on for frequent exacerbators on triple therapy. Monitor QT interval at baseline and periodically, and counsel patients about hearing changes.
Story 4. Atrial fibrillation and stroke. You have a patient who's had a stroke. They're in atrial fibrillation. They're on an anticoagulant. Should you refer them for catheter ablation to reduce their risk of another stroke?
It's an attractive hypothesis. AF causes stroke. Ablation eliminates AF. Therefore, ablation should reduce stroke. The logic is clean, but biology is rarely that simple.
A stable trial published in JAMA Neurology tested this directly. 249 patients in Japan, all with atrial fibrillation and a recent ischemic stroke, all on edoxaban, randomized to standard therapy alone or standard therapy plus catheter ablation within 1 to 6 months of their stroke.
The primary endpoint was a composite: recurrent ischemic stroke, systemic embolism, all-cause death, or heart failure hospitalization. Over 3 years of follow-up.
The result: no difference. The composite endpoint occurred at 4.9 per 100 person years with standard therapy versus 5.6 with ablation. Hazard ratio 1.11, completely null. The trial was underpowered, which the authors acknowledge. Event rates were lower than expected.
There were also 2 ablation-related serious adverse events: cardiac tamponade and a periprocedural stroke, each in under 1%. So the procedure itself carries non-trivial risk in this population.
Now, this was an open-label trial, and not all patients in the ablation arm actually received ablation. It's a real-world effectiveness question, not a pure efficacy trial, and the lower than expected event rates may reflect good anticoagulation with edoxaban across both arms.
So the clinical takeaway: in a patient with AF and recent stroke who is well anticoagulated, routine catheter ablation for secondary stroke prevention is not supported by current evidence. Continue anticoagulation. Refer for ablation if there are symptomatic AF reasons, not for stroke prevention alone. This is a negative trial that should temper enthusiasm.
Quick hits: PBS brand deletions for September 1st. Amoxil capsules, Cardizem CD, Actos, and Polyvisc are being removed. Generics remain available. Check your prescribing and transition patients to remaining brands before September 1st.
And the TGA continues its review of Tavneos abacopan for ANCA-associated vasculitis, following concerns about clinical trial data integrity. If you have patients on this drug, monitor the TGA website for updates. No action required yet, but be aware.
Recap: 1. PSMAddition showed lutetium-177 PSMA 617 added to standard hormone therapy reduces progression in first-line metastatic prostate cancer. FDA approved. Test PSMA status a diagnosis. 2. Blood pressure postpartum showed lifestyle interventions alone don't improve blood pressure after hypertensive pregnancy. These women need earlier, more aggressive cardiovascular risk management. 3. For COPD exacerbators on triple therapy, real-world evidence favors azithromycin over roflumilast. 4. Catheter ablation does not prevent recurrent stroke in AF patients who are well anticoagulated. Anticoagulation remains the key intervention.
See you tomorrow. Stay sharp.